Live.
We are live. I'm quite excited to be joining you today with special guest Peter Lansberg. Is that how I pronounce it?
That's right. Very good.
And you actually are a bona fide lipidologist. You don't just dabble a little bit in lipids, right? You actually practice.
Yes.
So how long have you actually been doing this? And can you give it just a little bit of a brief, like just a few minute background on how you came into it?
Okay, I started in lipids in 1987, working in Amsterdam when actually statins were introduced roughly in the same period. 1987 was lovastatin and simvastatin was 1989. I started after my medical school with a PhD program together with John Kastelein, who's also one of the lipidologists in the Netherlands who has fame and acclaim. I did a PhD study on familial hypercholesterolemia. And I also had a bit of affinity with IT in those days. So initially for our center, I set up the first electronic health record for lipid patients in order to have a better overview of the type of patients, particularly because we were also doing research. And in the course of, say, 3 or 4 years, I used that approach to distribute the concept of lipid clinics in the Netherlands. So we set up roughly 95 lipid clinics in the Netherlands, which is over 90% of all the Dutch hospitals. And that constituted of bringing them the hardware, bringing them the software. These were standalone machines. This was not yet, this was before internet. Training them in how to use the software, particularly the secretaries, and also providing them with background information on clinical cases, organizing CME programs to update them, organizing events to make them more known in the region so that GPs would refer patients. And that sort of snowballed into the lipid clinic network. And the lipid clinic network was a close association of roughly 100 lipid specialists that came together regularly. And initially, the focus was predominantly on FH patients. And to facilitate the diagnosis of FH patients, I came up with the so-called Dutch Lipid Clinic Network criteria for familial hypercholesterolemia. So that was the origin for that.
This is super crazy exciting to me because I actually have some very specific FH questions that I hope we'll get a chance to get into later.
Okay. So that sort of rolled onwards until roughly 1999, 2000. And then I was invited to set up the Dutch FH national screening program. And in that context, the lipid clinic network was quite essential because although the government subsidized this program, and this was quite an impressive sum of money, they did require that we had not only the capabilities of finding the patients, but that patients would be able to find a specialized doctor to be taken care of. And because the network was already in place, we could say, you know, there's a specialist within 50 kilometers of every patient in the Netherlands. So in 2000, I started setting up the screening program. And again, I think a major component of the success was the IT aspect of it, because we needed software to properly not only collect individual data from patients, but more importantly, also enable us to make graphical family tree drawings, because that was sort of the roadmap for the cascade screening of the family members. And last but not least, a workflow management that allowed we call them genetic field workers. Those were the nurses in the field taking care of screening those patients so that they had a good map of all the activities that needed to be planned. So that was a major project within the screening program, but that also was the biggest success factor. So we started setting that up in roughly 3-4 years. And after that, it just rolled onwards. And I think we screened up until 2015 when the program was stopped, almost 35 to 40,000 FH patients, meaning that we screened 130,000 family members and diagnosing roughly between 30 and 40,000 FH patients. Majority of them were treated.
Wow.
So those are probably the most relevant highlights of my professional activities. I'm still quite active in lipid, mostly in projects and also FH screening programs globally, Middle East, Eastern Europe, Southeast Asia, sometimes South American region, and a lot of educational activities. That's actually what I really like to do. I try to be involved with specialists or primary care physicians and help them understand lipids and how to properly manage those patients. So that's major activity for the last 2 or 3 years when I switched from a lot of the clinical stuff to more of the educational and writing stuff.
And a lot of people who are watching this, of course, are followers of my work, are themselves low carbers. You may be familiar with the phenomenon in that a subset of people who go low carb will see their cholesterol levels rise.
Yeah.
And in doing so, there is, of course, they're getting a lot of exposure from inside the community that's going to be a lot more on the skeptical side. Let's say that I was to ask you to go ahead and make the case that no, in fact, this is something to be concerned about, and here's the evidence to show why. Could you go ahead and do that for me?
Can I make a small introduction before I go into that? Because otherwise we'll skip a few slides that I think are important. One of the things that I think is something that people, let me see if I can get the next slide, is just to illustrate that cardiovascular disease is a real major problem globally. And that still 50% of people, I should say, die of cardiovascular disease. And that trying to curb that epidemic, trying to address those issues is, I think, really relevant. And focusing on risk factors, using lifestyle and using drugs, particularly very high-risk patient, is essential to reduce the risk of cardiovascular disease. I think sometimes in some of the discussions and Twitter and tweets that I get, that is, I feel sometimes neglected. You know, we're doing this because there is a huge problem in cardiovascular disease, and although especially the maybe a little bit younger generation, you know, when I was studying in medical school, cardiovascular disease was really a lethal disorder. And when a patient was brought into the coronary care unit, not many made it out alive. And that sort of changed, and sort of changed also the feeling that maybe it's not so relevant anymore. Or that's, you know, what do we worry about? Is it really something that needs to be addressed so aggressively as we do these days with managing risk factors and managing cholesterol? And I think it is really important. One of the aspects of lipid management is also, and this is just, you know, an illustration of leading causes of death in terms of other causes of death, and showing some parts of the world where cardiovascular disease has gone down in terms of the incidence, and where cardiovascular disease has risen dramatically because of changes in lifestyle as well. Let me see if I can get the next slide. Are you seeing this? No, I have to switch to.
You've got to share your screen.
I have to share my screen. Let me see if I can get this. Yes, this is this one, and this is this one. Is that working?
Yes.
Yes. Another important aspect of atherosclerotic cardiovascular disease is that it's a slow progressive disease. This is a disease that starts in childhood, literally. It starts when you're born, when you're 1 or 2 years old. And you get the manifestations when you're 50, 60, or 70, and in some people, sometimes a little bit earlier. Reducing that risk or reducing the outcomes, the negative outcomes, I'm sometimes really surprised how successful we are in using a drug that lowers cholesterol and seeing that severely damaged arteries are actually less prone to rupture or less prone to thrombosis. I think it's very nicely illustrated that if you look at patients with very advanced disease, and I'm talking about, for instance, advanced heart failure, advanced renal disease, dialysis, we've seen that particular risk factor management, cholesterol management, is not really that successful. And the major reason is, I think, that once the organ is really damaged, don't expect that lowering cholesterol will repair that damage. Don't expect that you can reduce events once the structure is so severely hampered that lowering cholesterol or doing something with the atherosclerotic fatty burden in the vascular wall will reduce those incidents. Really important, I feel, is starting earlier. As you can see in this slide here, that the process starts as minimal lesions, as fatty streaks, and progresses from third to fourth decade to really manifest lesions. And the only thing that we can sort of alter a little bit is what you see here. That's that yellowish mass of lipids that seem to be reduced once you are able to lower your cholesterol.
Now, if I could ask,
yeah,
and this gets brought up a lot. This graphic and a lot of the graphics we see that are like this suggest that it is progressive and not regressive. It suggests that inevitably these fatty streaks will continue to develop and become very thrombotic, and you've got greater narrowing of the lumen and so forth, and that there's really not much that can be done that stops or even reverses this process. Is that right?
It depends in what phase. I think it's quite clear if you look at, we have all these sophisticated imaging procedures now using nuclear magnetic imaging, optical coherence tomography, that allows us to really study what happens in the vascular wall once you, for instance, lower your lipids. And when the lesions are completely manifest, we're able to reduce the vulnerability of the plaques by reducing the lipid core. Now, this is still relevant because the lipid core is sort of also a driving force for the inflammation response, the inflammatory response in the vascular wall. And if you look at the development of atherosclerosis and the complications, I think there's two things you have to separate. There is sort of the slow progression of the deposit of lipids and the response, and there is the acute phenomenon of a rupture or a thrombosis, which is largely driven by inflammation and prothrombotic factors. So what is interesting in statins is that they are sort of a dual-edged sword. They allow you to reduce cholesterol, which has an effect on the cholesterol burden, but they also are powerful anti-inflammatory agents that are able to address the inflammation in the acute phase. And those two processes, although they are linked, you have to sort of separate them. We are able to reduce cholesterol by statins and by other means, and that has an effect on that slow progression of the lipid deposits. But statins are quite unique in that anti-inflammatory properties that seem to be quite beneficial in the acute phase. We are able then to sort of modify the plaque, but not remove the plaque. The changes we see in terms of thickness, in terms of changing of calcium deposits is not that impressive, but in terms of stabilization, and we see less lipids, less inflammation in those plaques of aggressively treated patients, and subsequently we see less events. Are we able to stop events completely? No, because the damage is already too extensive, and we can sort of stabilize it, but don't have the illusion. And I think it's virtually impossible if we start when somebody's in their 50s and 60s to completely obliterate atherosclerosis and cardiovascular disease. We can if we start at a much earlier age. I'm seeing you having a question here. Yes.
Yes. Well,
I'm
kind of gauging the pacing on how we're going to go, because I have devil's advocate questions, which I sort of have structured for a little bit later. And I'm feeling tempted to ask you some of those now, but I also didn't want to interrupt your slides. The only thing is I get the sense you may be you're pacing on the slides. We may need you to move through the slides faster in order to get to that point if you're wanting to.
Because there's one. This is I'm not sharing screen. I'm going to share the screen again. I'll go through the slides a little faster, and then we can start the discussion. Is this visible now?
Yes.
Yes. I like this slide because it shows you complexity. And when I started in lipids, it was easy peasy. You had bad cholesterol, you had good cholesterol, and you had.
Side note, I see these kinds of slides all the time in software development. So I like this slide too.
So, and I think this not even reflects 10% of what we know, probably even less.
I agree.
So realize the complexity of lipids and everything involved in system biology is almost incomprehensible. Now, what's even more challenging is you have to multiply this by 7 billion times, because for every individual, this diagram is different again. Yep. So, the way we are now toying with it is like, not in kindergarten level. We are slowly starting to understand what's going on in lipids, and we're learning as we speak. I'm going to skip this slide. I just wanted to show you this slide. Have you ever seen this slide before?
I think I have.
Well, this is published. Let me look at it. In 1913, this was a Russian researcher, a Dr. Anichkov.
Yes.
And he was the first to really sort of connect the phenomenon of atherosclerosis with A, cholesterol, and B, with lifestyle. So he did an animal experiment, and he used a rabbit model, and he was trying to find out if he could get these rabbits to develop atherosclerosis. So he gave them a very pro-atherogenic diet. And I'm sorry to say, but the pro-atherogenic diet was a mixture of egg yolks and fat, commonly known as mayonnaise.
Rabbits are herbivores, so this already was definitely very non-native, right, as far as the species goes.
Okay, let's discuss that a little bit. But what I'm showing here is on the left side, you'll see a plaque very reminiscent of what we see in human atherosclerosis as well. And you can observe all the classical features. You'll see the macrophages, you see the foam cells, you see a lack of smooth muscle cells, you see a lack of collagen fibers, and you see this plaque of cholesterol crystals and fats in the middle. Now, it took him roughly 90 days to get this plaque development in rabbits. 90 days from a healthy coronary artery to this. Then in his second experiment, he tried to reverse cholesterol. So what he did, he simply gave the rabbits back a rabbit diet, which is carrots and salad. And then on the right side, you can see there's almost a healed atherosclerotic plaque. All the riskful features are gone. There's now collagen fibers, there's smooth muscle cell, there's no inflammation anymore, nothing. So it illustrates that that's what he did. He lowered cholesterol again to a very low level. He was indeed able to reduce that risk significantly. Developing it was in 3 months. It took roughly about 2.5 years. Now, when he published this, he was also ridiculed, and his colleague researchers claimed the same thing. They said, listen, these are rabbits. We are humans. How can you sort of extrapolate rabbits and humans? And of course, to a certain extent, they were right. Rabbits and humans are different. But the crux of the argument is rabbits are vegetarians. And humans, and you can base that a little bit on physiology, on how we digest food, on our teeth. We are sort of omnivores, but we are more reminiscent in terms of the length of our intestine, in terms of how we can metabolize cholesterol, in terms of our teeth, more reminiscent to the vegetarian type of animals in the animal kingdom than the real meat-eating animals in the kingdom. So I think that also advocates that using an approach where you flood the system of these type of animals, had he done this with rats or with a dog, he would have failed, because they are quite capable of handling these excessive amounts of fat and cholesterol. But in a rabbit model, it was very successful, and you can sort of debate if this is something that is relevant for humans as well. Let me see if I can show you the rest. Yeah, this is another important slide for my argument why I think cholesterol is really important. These are three lines, log linear correlations between what you can see here is the level of LDL cholesterol and the risk of cardiovascular disease. And these three lines represent trials which are randomized controlled trials. These trials usually last for about 4 or 5 years. Then we have the second curve, which are observational epidemiological studies. So they have an observation time of roughly 10, maybe 15 years. And we have what we call Mendelian randomization data based on genetic differences that are responsible for changes in cholesterol. So this is not like a single gene like in FH, but a combination of different genetic tweaks. And each of those tweaks gives you a little rise in cholesterol. So if you have a lot of these tweaks, your cholesterol can rise actually quite significantly. And what you can see is that if you go from randomized clinical trials to registries to Mendelian randomization, that the change of LDL cholesterol translating in a reduced risk increases from randomized controls to, for instance, Mendelian randomization. And we think the reason for that is the exposure time. So with Mendelian randomization, you're talking lifetime exposure from birth until you do your measurement. In randomized controlled clinical trials, it's a 5-year exposure. And you can see that a 5-year exposure translates in roughly half the risk reduction as what you see in randomized in Mendelian randomization. So if you look at trials that last 4 years and you lower cholesterol by roughly 30 to 40%, you see roughly a 30% risk reduction. In Mendelian randomization studies, if cholesterol was lowered by roughly 30%, you see a 90% reduction in cardiovascular disease.
Now, can I ask some questions on this slide?
Yeah.
So a criticism that I think is fair with particularly those in the nutrition world is a lot of times they can cherry pick. They can choose particular things. And a lot of times this slide is what's brought as a good example of, well, if you look at a very large swath of evidence that's across 3 different lines, right? The Mendelian randomization, cohort studies, randomized control trials, you can see that on the whole, there's quite a lot of evidence that suggests there's this log linear relationship. Now, that said, let's kind of take these one at a time. And actually, let's start with the drug trials. Now, the drug trials that are up there are not all of the drug trials conducted that reduce LDL cholesterol, right? They still have a selection criteria from which they determine what was going to go up there that are in the orange dots and with the orange line, right? So I
think there are a fair amount of the clinical trials using statins or using lipid-lowering drugs are in there.
Well,
yeah, go on.
let me use it. There's a recent example of cholesterol ester transfer protein inhibitors, of course. And as you and I both know, that's been considered a failed drug.
True.
Generally considered a failed drug line, in that while it succeeded at lowering LDL and succeeded at increasing HDL, it ultimately resulted in higher all-cause mortality.
Yeah.
Now, I can understand why a skeptic would come see this graph and they'd go, now, wait a second. You're choosing drug trials that meet the narrative that you're looking for, in that there is a lowering of LDL and there seems to be an outcome that you prefer, and basically classifying those drug trials that did succeed at lowering LDL but failed at lowering mortality as irrelevant and not necessary to put up against the evidence of everything else, right?
Yeah. Okay. And let me address, because this is really interesting and I think really exciting as well. You're right with the REVEAL trial. We were a little bit shocked because there was indeed a 40% reduction of LDL cholesterol, but there was almost, it was like a 14% reduction in cardiovascular risk. Now, I'm not even going to talk about HDL, because I think in lipidology, HDL is sort of stricken off now. The way we looked at HDL, and if you like, we can discuss this a little bit in depth later, but HDL is sort of, let's forget about HDL. It's too confusing. We don't really know what we're looking at, and it makes life really difficult. Now, in terms of LDL, when we started in lipids, we measured total cholesterol. And then we started realizing that maybe LDL cholesterol is a better marker, and we used the Friedewald formula to calculate LDL. And then in the next step, we said, no, you know what, maybe non-HDL is actually a better marker. And over the years, we progressed, and we are now at a point where we say, we think that ApoB, or LDL particle number, actually much better reflects the risk associated with this type of cholesterol, or this type of particle, actually, I have to say, because it's not the cholesterol per se, it's the type of particle that determines the risk. Now, what was interesting in the REVEAL trial is that ApoB was only reduced by like 16 or 18%. And what we observed with the CETP inhibitor is that although cholesterol shifted from one particle to another particle, the number of particles, and like I said before, we feel that is a better predictor of risk than actually just looking or measuring LDL cholesterol, was not moved that impressively. So if you look at the reduction in ApoB, it still falls exactly on that same line as we call it the CTT regression line. The cholesterol trialist combined all that data to come up with this regression line. And then the CETP inhibitor does reflect actually what we thought. Only the amount of LDL cholesterol was not really the right marker to determine that risk.
But you see my point. My point is the CETP inhibitors are not going to be on this graph. They probably won't even be in any major meta-analyses, because when it seems from a distance, and correct me if I'm wrong, if a drug successfully lowers LDL but fails to lower mortality, it's considered a failed drug trial. And even though that data is data where we're actually observing a lowering of LDL, that's considered irrelevant and is not part of the larger literature. When a drug instead lowers LDL but succeeds at somehow having an improvement on mortality or events, then it's actually considered both a successful drug trial and further evidence that lowering LDL is beneficial.
Okay, really interesting discussion, because I think what we're talking about is LDL a causal risk factor or not. If LDL cholesterol is a causal risk factor, no matter how you move it, it should go down. I think we were perhaps not as accurate when we decided that LDL cholesterol was the causal risk marker, and that LDL particles are actually the real culprit, because it's LDL cholesterol is a reflection of LDL particles, and LDL particles is what it's all about. Or you could say maybe LDL and remnant particles and Lp(a) particles, but they're sort of the same family. And
Actually,
measuring.
I'm sorry to interrupt. I actually, this is kind of a thing for me. I actually really make a distinction between ApoB and LDLP. I think it's important. ApoB comprises both remnant lipoproteins and LDL particles. I'm especially interested because we have a large data set now of people who are low carb, where they have actually very tiny levels of remnant lipoproteins and therefore remnant cholesterol, very large amount of LDL particles. And that kind of goes back to where my energy model is. We probably won't have enough time to get into that, but I suggest that there's a particular reason why we may be seeing this phenomenon for which it makes sense. And that's why I've also been in pursuit of all studies that don't just look at ApoB, because that could include higher levels of remnants, but in particular LDLP. So I know it gets used interchangeably a lot, to be sure, but I do want to make that emphasis that that's something I try to zero in a lot, in that if you're looking just at ApoB and it's including remnants, then it's not as useful of a marker to me than looking at just LDLP. I am interested in whether or not high levels of LDLP will induce higher levels of atherosclerosis under any context.
That's something that, the LDL level, and if it's really relevant or not, is something we can discuss in the context of FH, because I think it's a prime example, and I have very nice patient to illustrate that actually, that LDL definitely is the culprit. And even in low triglyceride, high HDL, don't be fooled in thinking that LDL is then sort of harmless. No, LDL, by its particle size, by its particle constituents, by the fact that ApoB is targeted by pro-oxidant and pro-acetylogenic and glycosogenic attacks, making it a more aggressive particle. This is the real deal, and predominantly what we find is LDL circulating in the plasma and having an overflow into the vascular wall because of its excess and in certain vascular circumstances. Now, the remnant particles, yep.
Because I think it is a good segue to chat. Why don't we go ahead and flip back to our cameras, and then we can actually talk.
Oh, sorry. Yeah, I forget.
No worries. I really do actually want to drill in on FH, because I do think that the case is often made, and it sounds very compelling, that, look, you have a genetic disease that's been known not just in like the last few decades, but for a very long time, that results in extraordinarily high levels of LDL particles, not just LDL-C, but LDL particles.
Yeah.
And because of this higher level of LDL particles and the presence of very early onset atherosclerosis, this seems to very effectively substantiate the lipid hypothesis. You'd say that's a pretty fair introduction to that, right?
Yeah.
Now, this is where I want to kind of make a distinction, and I want to be as fair as possible on the approach. Even though the term, as I'm sure you're aware, familial hypercholesterolemia has been kind of relaxed and expanded to some degree, for a very long time, it was very specific, like its traditional term was more towards the mutation and the LDL receptor itself. If you had homozygous familial hypercholesterolemia, then you had both alleles were in trouble. You had very poor binding to LDL particles. And where this matters is the assumption is the liver is not taking up the LDL particles at its normal clearance rate, leaving more of it in the bloodstream, and therefore a higher concentration gradient, and therefore likely a higher protrusion into the endothelial wall, right? Heterozygous is the more common but less deleterious version. So the homozygous FH, as you said, kids having heart attacks at like age 10, right?
Yeah.
Whereas somebody with heterozygous FH might be more at risk for a heart attack, but it may still be several decades later because
Sure.
they have at least half the binding affinity of those LDL receptors. Now, with that setup, here's the part I want to bring in that I find to be extremely important. I find the genetic studies to be extremely interesting. Yet, the thing I want to remove is whether or not there is endothelial dysfunction preceding the atherosclerosis. So if you're taking away a cell's ability to uptake LDL particles, is that putting the health of the cell at risk? If they can't either uptake lipids or lipoproteins, particularly if they're using the raw materials of the phospholipids and the cholesterol, et cetera, is that actually going to potentially create dysfunction or even damage to some degree, right? And that's why I started looking into a lot of studies that had to do with whether or not this was, whether we could see endothelial dysfunction ahead of atherosclerosis. And I have found studies, in fact, you may already be familiar with, there's FH studies for which children with FH will show endothelial dysfunction, for example, problems with vasodilatation ahead of signs of atherosclerosis.
I think that the problem of FH is not a endothelial cell problem. Each and every cell, except one, is capable of synthesizing its own cholesterol. It doesn't depend on LDL cholesterol. LDL cholesterol is something that is sort of some people think it's completely redundant. I think it's probably overexpressed in our westernized environment where there is too much food and not enough energy expenditure to deal with that. But every single cell does not need LDL receptors to make sure that it can keep its homeostasis in order. It can do so itself, and it's an enzyme that's upregulated as soon as the amount of intracellular cholesterol goes down. The synthesis will go up, and to synthesize cholesterol, you don't need cholesterol. You need acetyl-CoA, and that is a energy-rich substance that can be that can come in from other sources. Now, what happens with FH children is that their endothelial function is sort of impaired because of the influx of LDL particles through the endothelium, through the small gaps in the endothelium, and ends up in the interstitial space. And that attracts inflammatory cells that release all kinds of vasoactive substances, and that also have a damaging effect, apoptotic effect on some of the cells that are in the neighborhood. So these could be small muscle cells, or these could be endothelial cells. And those damaged endothelial cells then by itself can again attract more white blood cells. So you get sort of a vicious circle, a snowballing effect that accelerates that process of atherosclerosis. And what we see in FH children, and what we try to test, although it's very difficult, is that you want to have sort of a measure of effectiveness if you treat those children. Predominantly, of course, when you treat them with drugs, because you want to show that you're doing something good and nothing harmful. Now, it's not really advisable to do a coronary angiography or an IBUS in children. So we try to do non-invasive measurements. They're too young for calcium scoring. So there were two methods that in Amsterdam, where I used to work, were quite prominent, which is a CIMT, a carotid IMT measurement, and a vascular function measurement, which is you compress the brachial artery and then you release it and you measure the diameter of that vessel. And if it has normal reactivity, it should be wider after the release of the cuff. It's sort of a reflex.
Right.
And we see in children that are not being treated that reflex is absent, and that you can see hardly any changes, or sometimes even a narrowing of the artery. And we call that endothelial dysfunction. And one of the prime substances involved in that is nitric oxide synthase and nitric oxide. And once you start treating them with a statin, you see this improvement. And partly is because there's, I think, anti-inflammatory effect and this LDL cholesterol lowering effect that reduces the burden in the vascular wall, and then also reduces the burden of inflammatory cells that produce all these vasoactive substances. So I think that is a little bit the mechanism that, from my perspective, explains some of the things that you're referring to.
So, for example, and I like the CINT as well. You see in children with homozygous FH, you're going to see a much faster advancing of CINT relative to cohorts of their age. Would that be right?
Yes, yes, yes. So there's one caveat with IMT, and I can explain that because I've been very close to the development of IMT. And in the beginning, we were very excited because it was, particularly in children, it seemed something quite promising. And we did indeed show that there were differences in the siblings. So when we looked at families and one of the children had FH and the other one didn't have FH, and we measured their IMT, even at an early age in their teenage years, we could see there were differences in the thickness. Now, realize these thicknesses were very, very minute. You know, we're talking tenths of a millimeter. And that the resolution of the devices we use to measure that, that's almost beyond their capability to detect it. Another important factor is that measuring it, although the technique is not difficult, but to be a really qualified and trained technician, it takes a lot of time and effort. And also the procedure itself, you have to make sure everything stays the same. The position stays the same, the location stays the same, the temperature in the room stays the same, the condition of the patient, he didn't have flu the night before or had an alcohol binge the night, and that's why IMT has sort of been, a little bit drifted away due to these challenges. I still think, and I still see that in clinical practice, it's being used partly to see if there's real thrombosis in the carotid artery. If you can see real plaques in the carotid artery, that's also a very ominous sign. Some people use it to track progression or regression as a sign of, you've been properly treated, and also to motivate patients. But there is a large error in the measurement, so we have to be quite careful. And for flow-mediated dilatation, that's even worse. So that has already been completely abandoned as a sort of surrogate tool to see how effective a treatment is for these type of children.
So I'm sure a lot of viewers are expecting me to already say this. I actually have been publicly posting my own carotid intimamedia thickness tests, my own CINTs. I don't know if you've been following.
No.
I had a total of 6. It's been taking place every 6 months. For the first 4 of those tests, I was primarily on a ketogenic diet, save the experiments that might have taken me out of it. In all 4 of those, they had slowly been showing regression, even though my LDL cholesterol has been in excess of 200 milligrams per deciliter. My LDL-P particle count has been in excess of 2,000. Now, on the 5th test, I had just completed a 4-week weight gain experiment. The longer story as to why I did that, but it was important for a lot of the tests that I was doing, and I was very interested to see if that would have an impact on my CINT. And it certainly did. It had expanded to the 80th risk percentile on both sides, both the left and the right side. And I was a little more okay with it in that I was kind of banking on there being regression again once I returned to a ketogenic diet, even though I knew my I'd have higher LDL-C and LDL-P, particularly given that I knew it's a very anti-inflammatory diet and so forth. And I've now observed the regression again. I suspect I'll see still either the same level or even further regression on the next CIMT, which will take place in May. But this does kind of run counter to the narrative of not just what you're saying, but also what they say in the literature for CIMT, that one of the risk factors that produces a greater level of CIMT thickness is higher levels of low density lipoproteins, the particles themselves. That's why, like, I'm interested in this particular subject, especially in terms of what you've just described is what I've heard many times before. It's not just you as well, that this concentration gradient of LDLP being higher is what causes the endothelial damage and then brings about, the inflammatory response and so forth. But I have to say, it's not just been mine. I've seen many of these people who are hyper responders inside the low carb community, especially the group, I don't know if you're familiar with them, lean mass hyper responders. They have the cut point, the starting point is LDL-C of 200. And I've seen not only LDLPs that are in the 2000s, I've seen them much higher. I've seen them at LDLP of maxing out at 3,500. But I encourage them to consider getting CIMTs. And if they do, they turn them around to me. They're looking amazing, even though these are FH levels of LDLP. So I continue to be somewhat surprised because I do feel like there's still another major component beyond just the particle count itself.
We have to be careful because these changes in such a short period of time are quite minimal. We're talking about on the fringes of the resolution of the machines that we're using to do these measurements. I know from personal experience that although you really want to be objective, sometimes you interpret what you like to see. Is the bottle half empty or half full? And you can sort of, I think it's half full because I think it's going to be positive for me. It's not even difficult. It's impossible to say anything about the outcome in the context that you're doing it now. It could be. I doubt it, but in medicine is not mathematics. It's biology, and sometimes there are strange responses. So I'm unable to completely negate everything you say, but I do think, from my experience and what I've seen, I think it's quite unlikely that you will not have any harm from having higher LDL or higher LDL particle numbers in the context of what you're doing. Now, don't get me wrong. I do think your approach to reducing the risk, and we can discuss if a ketogenic diet is the ideal one or not. I'm not going to go into details right now, but it's like this. If you are in perfect health compared to somebody who's not, and your only risk factor is LDL cholesterol, you're probably better off than the other guy. But if you're in perfect health and your LDL cholesterol is down as well, which of the two people would be better? I would put my money on the same person. If you do sort of a control experiment.
Yes.
The person.
Yeah. Well, this is what I want to get to. So look, your point is well taken on confirmation bias, 100%. It's why, like, I wanted you to present, the counter case, and so that we could get a chance to talk about it. I've been looking forward to the day. If I could do this every single broadcast, I'd be doing it, right? The reason I brought it up in this context is because you're right in that we're talking decades of development potentially with atherosclerosis, even under the best conditions. And you can search all my media. There's no point in which I've ever said I'm certain low level or high levels of LDL-C are not a problem, or high levels of LDL-P or whatever. I feel like we're far away from understanding that fully, particularly given the mapping you just showed. But I am looking for all cases, particularly where we can look at what is kind of held up as the key foundational example of high LDL particles equals high atherosclerosis, and that is FH. And maybe I'm wrong about endothelial dysfunction and damage, or maybe it's something else, but I am looking for all proxy markers for which we can check any kind of progression of atherosclerosis. And that is commonly one of the CIT, the brachial one, for example, that you brought up as well. CTAs, CACs, a lot of these are different ways by which we can at least get a running capture of what we would otherwise see more progression in with people with FH. And let me tell you, I'm anxious to find out if in fact there is a genuine risk factor, even if it's not atherosclerosis, even if lean mass hyperresponders turn out to be at risk for something else. I want to find out as soon as I possibly can. And that's why I'm interested in FH in particular, and why I'm interested in making the comparison. So it's really the comparison with people who have homozygous FH that I'm interested, because many people who are these hyperresponders at the far end, they have levels typical of those people who are already at FH between like heterozygous and homozygous. That's why there's this level of interest, I guess you could say.
Yeah. Well, you know, one way I look at the things that you just mentioned about the hyper responders, and I believe it's roughly 20% of the people on ketogenic diet, somewhere in that. Yeah,
probably.
So the way I interpret it's like what we see in drugs. You know, you have responders, you have non-responders, or you have paradoxical responders that instead of you give a statin and or you give a CETP inhibitor, and instead of HDL going up, it goes down. You know, there is you know, response and there's non-response. So it could be simple like that, and then we can discuss, you know, the mechanism and insulin, how does that play a role, etc. Anyway, I just wanted to show you this patient because this was my $1 million or $1,000 patient. Let me see if I can.
Was it 1,000 or 1,000,000? That's quite a difference.
Now, this patient is actually quite a bit of a history. This was one of my, it's not a picture of her, but it's somebody who looked like her. It's one of my first patients when I started my lipid career. She was in her early 30s. She was a lawyer. She had just finished her law degree and was now trying to practice as a I think a business type of lawyer. She was just married, she was buying a house, and you know, I was just starting in my career, so we had sort of a rapport. You know, I was doing my medical thing, she was doing a legal thing. And she got to me because we gave a presentation for GPs about FH. And the GP had a patient, which was her father, that actually had an AMI at an early age in his 40s. And he remembered that we told him, well, if there is a young FA, or if there's a guy or a girl with a young age event, please check family members. So he did that, and he found that the daughter had a very high cholesterol. And he said, please go to this lipid clinic because maybe they can help you. So I was the first one to see her. And as you can see, and she was extremely healthy. She was, you know, she had a BMI of like 19 or 21. She was bicycling. She was doing a lot of sports. She tried to eat a healthy diet. She did smoke, but not heavily. And that's something that she stopped after the first visit. And then she actually increased her physical activity. And this was like in the beginning of lipid management. So we're talking like 1990 or 1989. And in those days, we had like 10 or 20 milligrams of simvastatin, maybe 40 milligrams of simvastatin. And you can see what I did. You know, I started out with an LDL of 8.3. So we do that times 40. So that's 320 milligrams per deciliter. And then we started with 20 milligram, and she ended up with an LDL of 4.7, say 5. So that's roughly 200 milligrams per deciliter. And in those days, it was still slightly elevated, but we had something, you know, and she was not really happy about taking medication. And as you also can notice, her HDL was quite high. Her HDL was 100, even over 100. And the triglycerides were low to normal. And this was roughly after about 6 months of treatment. So she said, you know, I suggested maybe you should go 40 milligram. And she said, no, can we try 20? And I said, okay, let's try 20 and come back in 6 months and we'll see. I didn't see her after 6 months, but after a couple of weeks, her brother called me. Her brother was actually an MD as well, working as a radiologist. And I said, listen, I have some bad news. My sister was bicycling with her friend in the park, and suddenly she fell off her bicycle. Now her friend happened to be a GP, so she tried to do CPR and resuscitate her, but she was unsuccessful. So she died on the spot.
Mm.
Because of her young age, they did a post-mortem examination and they found extensive atherosclerosis, not a little bit. They even found old scars of silent infarcts before. And for me, this was really an eye-opener. That really gave me such a kick in my belly that I thought, no, this is, how could I have had this happen? I should have been more aggressive. And I always use this for presentation because it makes a few important points. First of all, it's a young woman, and people never think that women are at risk. Second, she was completely healthy. Okay, she smoked. We're talking about 1989. This was a time when that was not so uncommon. And she had very high HDL. And although it's getting less, there are still people that say, if HDL is high, we don't need to worry. And we used something called a ratio in those days. Her ratio was 3.4. So that's something below 4.5, which was considered to be an important risk factor as well. So it illustrates that despite everything in line, now I'm sure she didn't follow a ketogenic diet, but she did, she did her best by eating a healthy diet and doing a lot of exercise, and that the impact of LDL was really tremendous. And this is not unique. This is something that you observe quite commonly. I didn't put the slides in there, but I can show you some data on FH patients who have similar profiles, high LDL, normal to elevated HDL, normal to slightly lower triglyceride, and still a big impact. So that was what you were looking for, to find those individuals. Well, in FH setting, they're there.
Well, given that HDL and triglycerides as an axis often can be a proxy in many respects for insulin sensitivity, it's definitely data I would be very interested in. I'm especially interested, I know that this is harder and harder to come by, but I'm especially interested in an untreated population of those with heterozygous FH. I realize basically my best chance is to find native populations, some indigenous people who just happen to have it and didn't have any doctors that detected it, because it's too, you can't get a study of like a true placebo control trial with those people have FH. For them, I can't even do it with people who don't have FH at this point. But I do find it pretty important.
Yeah, we did have, one of the studies we did, because in the Netherlands, we did a lot of FH research. So there is one article where we looked at outcomes in FH patients. And we compared the ones that were treated with the ones that were not treated, because they didn't want to, or because the GP said it wasn't necessary, or because they couldn't tolerate, for whatever reason. And we followed them for 10 years. And if you compare the ones that were treated with the ones that were not treated, there was an event rate of approximately 40% in the ones that were not treated, while the ones that were treated were almost in the range what you would expect for a non-FH population.
I would normally, and this isn't just being dismissive, I would normally have a problem with healthy user bias. Healthy user bias is already an issue with studies that go in the direction of the keto diet and so forth. I mean, the trick is you want a population that wasn't aware of or you weren't aware of their own eating styles or their own health choices or so forth. And unfortunately, people who turn down treatment are more often, I should say, the people who may not consider their health to be as of much value, or for that matter, are just more skeptical of anything, not just, good health advice that might come from the medical community, but even from nutritionists and so forth.
Be careful in that sense with FH patients. I mean, I'm sure not 100%, but what's very interesting in FH patients is that probably based on their family history, they're very aware of healthy lifestyle. So if you compare even untreated FH patients, their BMIs are lower. Their food intake quality is much better. They're more aware of healthy activities. So it is a group of people that by the nature of the disease, I think, are much more aware of the context and are quite eager, not all, but quite a few, to do something extra to maintain that health. And the reason why some FH patients are actually not being treated is, tolerance issues, is because sometimes doctors are not that convinced and realize not all FH patients have LDLs up in the 300 or 400. Some of them have a little bit more modest. And last, but certainly not least, it's sort of, they don't want to be confronted with it. They try to hide away from it, put your head in the sand and pretend it's not there. That's something I encounter also quite frequently with FH patients, that they just don't want to be confronted with the fact what they have. And I even had homozygous patients who refused treatment because they said, I'm going to die anyway, so I might as well enjoy my life and not go for an apheresis or.
Right, but that's my point. Is like that. I don't want a population for which one side goes, I want to take action to extend my health, and the other side goes, I feel defeatist. I'm going to go ahead and ignore actions for my health, so I'm going to live for today. The problem is that creates the bias already, and it's a tough problem because, again, I'm trying not to weigh it all on one side, and it's one side's problem and not the other side's problem. It's why, really the best way to get a truly untreated FH population is if they themselves were unaware that they themselves were living the life that they would have with their cohorts in the place that they were at and had just never gone to a doctor, or had just never, or their, village or town or whatever just doesn't have a lot of healthcare, so that you can make a likewise comparison with their cohorts. And again, I know that's a big challenge. That's a really hard problem to tackle, but it is, for us to better understand the disease.
I have seen FH patients with very high cholesterol levels up until the 90s with no events, where these patients that were, completely insulin responsive, and I don't think that was sort of a characterizing features. Always when we discuss these things, also with the patients themselves, they say, how come? Why? My brother had an MI at 40. I am now 90, and somehow everything goes well. And then I always explain to them that one of the features that probably could play a role is that we have risk factors that circulate in the blood and that pass through the endothelial barrier and end up in the vascular wall and have an inflammatory response. Maybe some of these patients, they have like a Teflon layer on their endothelium. The endothelium is really very good in protecting what's behind it, or they have a different inflammatory response that is not as aggressive as we see in most people. I don't think it's really solely related to insulin levels and insulin response, because I don't remember seeing that as sort of a connecting feature. And I also have to say it's quite rare. It's not something that, every 10 FH patient there's one that becomes 90. No, it's very uncommon, but they do exist, as everything in medicine we know. There's exceptions. That I always say exceptions make the rule. That can have a long lifespan without it. It doesn't mean, by the way, that then their brothers or sisters or their siblings or the children share that protective quality, because that doesn't work that way. I've seen parents that became 90 and children had their event at 26.
So I'm actually going to go ahead and skip through. Well, we're going to go ahead and go to the devil's advocate questions real quick.
Okay.
I feel like we've covered a little bit of this, so a little bit of this will be kind of a repeat, but I'm going to go ahead and jump to this real quick, and this will have just a little bit more of a setup. And on the first one, I really want to emphasize this is a place where we likely agree. LDL particles are involved in atherosclerosis. Yes. If you have no LDL particles, you'll have no atherosclerosis, right? However, atherosclerosis is a multifactorial disease. You just mentioned LDL particles are necessary but not sufficient. By the way, I've lifted that from Peter Attia. Now, this isn't a trick statement, but it is relevant. You could say the same thing about macrophages, right? The foam cells are, in fact, a combination of the two. Macrophages are activating the immune response, are coming in and so forth in order to make this happen. Well, in that sense, here's my first question. Are LDL particles like macrophages also part of the immune response? Don't we already have a lot of literature that shows that LDL particles are in fact recruited as part of their immune response? And for that matter, that endothelial cells can do, for example, higher expression of LDL receptors when they're in trouble, or things like if you inject somebody with lipopolysaccharides, there's an upregulation at the liver to actually bring out more LDL particles. And as a follow-up, if that's true, if so, is it possible that some cardiovascular disease is a result of an acute or chronic immune event? Now, again, I'm not saying all, but even if there's some, is it possible that some amount of what we're observing with atherosclerosis is actually a response as opposed to something that was initiated by LDL particles alone?
So let me see if I understand you correctly. One view that's commonly held is that, there's a trigger of LDL and the immune response, and you're sort of posing maybe the immune response is leading. You have sort of an abnormal immune response that promotes atherosclerosis, even though maybe LDL is at a very low level or LDL is not important. Is that what you're trying
Sure.
to?
Let me even give a more distinctive example. We already know in mouse models that you can denude their like carotid arteries, right? And that this can result in a reparative event that ultimately initiates atherosclerosis.
Mm-hmm.
In that sense, we already know that there can be endothelial damage or dysfunction for which there's already a built-in process within the body that could result in a very site-specific area for which we can anticipate atherosclerosis would occur. Mm-hmm. So how sure can we be that atherosclerosis, wherever observed within the human body, was in fact due to LDL particle penetration from a gradient as opposed to some sort of dysfunction or damage, and therefore likely part of like the immune response?
We have certain type of autoimmune diseases like SLE or antiphospholipid syndrome, where the immune response is hyperactive and where you can see also a problem with atherosclerosis. Again, from my perspective, I do think LDL particles are really pivotal, even in those maybe hyper responders in terms of immune response. Let me put it another way. Other triggers for heightened inflammation, like for instance, smoking. We have some old data from Japan that in Japan in the 1960s, where smoking was like 80% of the Japanese people smoked, and their LDL cholesterol were not really that high. You would expect that because of that powerful effect of smoking and that that pro-inflammatory stimulus, you would see rampant cardiovascular disease. No, you didn't. Cardiovascular or coronary disease was almost non-existent. We did see stroke, but predominantly hemorrhagic stroke. We think it's related to the hypertension and to the high salt intake, that was sort of a causative factor. But coronary atherosclerosis was quite absent, despite that really omnipresent smoking status in Japanese. And what we saw, and it was a really interesting study, it's called the Ni-Hon-San study. Ni is Nippon, Hon is Honolulu, San is San Francisco. When these Japanese moved from Japan to Honolulu, their risk increased. And when they moved from Honolulu to San Francisco, it went even further. And if you looked at the risk factors, that was,
We'll make anybody unhealthy. Just come on over here.
And what was even funnier, if they moved back, the risk stayed high.
What?
but on a different note, we did a study with colleagues in Canada where we looked at Chinese FH patients in Canada. Now, in China, these FH patients had cholesterol levels, say, of 300, 400, and had very premature atherosclerotic disease. This was in the 80s or 90s as well. And then we looked at family members in China, but the family members that were living still in rural China in those days, where they got a minimal amount of food and had to work very, very hard to get that minimal amount of food. And intriguingly, their cholesterol levels was actually, with the same mutation, roughly half the levels of what we found in their westernized counterparts. And also the incidence of cardiovascular disease was slightly higher than what you would expect in Chinese, but a lot lower as their counterparts in Canada. So you can see environment, even in the context of that strong genetic force, does play an important role as well.
Let me go ahead and move to the next one. But this, I'm going to do a little bit of a wind up. You may not have seen this graphic before, but I pushed it around.
I don't see the image. I don't see the image.
You don't?
No.
You may have yourself selected in the squares.
Oh,
down
yeah.
below.
Oh, yeah. You're right. Let me see if I can. Yes, you're right. Yeah.
No worries. So this graphic, this has been what I call my low carb cholesterol challenge. It's about to hit a year, by the way, on February 14th. I think it's on Valentine's Day. And basically, I really wanted to emphasize that there seems to be a lot of pushback on high LDL cholesterol when you're on a low carb diet. But in particular, I've wanted to find studies for which there's low triglycerides and high HDL, which you've kind of addressed from earlier. And to kind of put it a little bit more directly, I just call this the lipid triad. I call it this way all the time. So high LDL cholesterol along with high HDL cholesterol along with low triglycerides, can it be that this actually equals low cardiovascular disease? And I have only 2 studies that I've been able to find up to this point that actually puts all 3 of these together, this triad together, specifically these 3 in this combination, high, high, and low, right? Now, you already know there's a commonly referenced other triad known as atherogenic dyslipidemia, which is like a flip of this. It has low HDL cholesterol, high triglycerides, and not high LDL cholesterol, but high small low density lipoproteins, right? Here's the 2 studies that I'm speaking of, and one of them is Framingham. This is actually Framingham. And this is a chart directly from theirs. Now, as we would expect, triglycerides being under 100, LDL being under 100, and a high HDL-C having an odds ratio of 0.6 being the best one is one we would have expected. That's great. However, when you actually look at LDL above 100, everybody above 100, but they still have high HDL-C and low triglycerides, or even above 130, the line down there at the bottom, they are still at a very low odds ratio. They're actually doing exceptionally well. They don't even hit 1.0, right? Now, let me actually jump to the one other study. And this one I like even more because it had an even higher level. This is their graph. And as you can see, they divided between an LDL-C. Let me see if I can make my mouse move a little bit. This is an LDL-C of 170 at the low end, below 170 and above 170. And of course, in millimoles, this is 4.4 and 4.4. And you can see they then created tertiary after that point of those people who had, and the dark bar, I don't have the graphics for it, but the dark bar is people had, I believe, an HDL above like 57 and triglycerides of under 97, I want to say. And what's striking about that to me is you see that they're almost identical, whether you had high or low, so long as, like the dark bar shows, you have low triglycerides and high HDL. But even more shocking to me is that it's almost identical on the other side. If you have high triglycerides and low HDL, whether you had low LDL or not, you were at super high risk. And so it's things like this that make me wonder if, as you were talking about a little bit earlier, you were first looking at total cholesterol and then you found a better measurement. The better measurement was LDL-C. And then you found a better measurement than LDL-C and it was LDL-P. What if the better measurement than LDL-P is HDL-C and triglycerides, even though they've been there this whole time? So I think I actually highlighted down here. So yeah, this leads me to my devil's advocate question too. As more evidence emerges that stratifies for this triad, specifically high LDL-C, high HDL-C, and low triglycerides, do you likewise predict it will show lower risk of cardiovascular disease?
To be honest, I don't think so. First of all, high HDL-C, in the traditional Framingham cohort, they always said if your HDL is very high, it's very unlikely for you to develop cardiovascular disease. And that's sort of rolled on and developed with the CETP inhibitors, that increasing HDL would also translate into higher risk. I referred earlier with LDL to the Mendelian randomization studies for LDL. They've done Mendelian randomization study for HDL as well. And again, it was not possible to make that distinction if you had genetic markers associated with slightly higher HDL or slightly lower HDL. There was not a real indication that that was associated with risk. Intriguingly, that was the case for triglycerides. So triglycerides that in the past always have sort of been swept aside and neglected and said, you know, they're not really relevant. It's HDL that's important. We now see the opposite. Triglycerides seem to be more predictive of developing cardiovascular disease. And I wouldn't be surprised if that is partly also related as a causative factor to insulin and insulin resistance. And then subsequently you have small dense particle, or you have more circulating particles that promote and stimulate atherosclerosis. So HDL in the equation is very difficult to interpret. There's too much confusion about HDL that makes it, at this point in time, until we have a very good marker for HDL quality or HDL function that makes it possible to distinguish, you know, this is the right HDL. HDL cholesterol doesn't say anything about if this is a particle that's protective or that's actually harmful. You know, if you look at HDL in patients who have renal disease, or patients who have diabetes, or even patients with cardiovascular disease, the properties of HDL change dramatically, and it becomes from an anti-atherogenic a pro-atherogenic particle. So instead of being protective, it actually promotes what you're trying to prevent.
Now, for what it's worth, I agree with a lot of what you've said. The one distinction I would make is HDL-C by itself is not as good as being able to see high density lipoprotein function. The catch is that HDL-C is data we already have. So the reason I'm interested in that triad, and why I want to get your prediction, really everybody's prediction, is I'm in hot pursuit of looking at existing data sets and trying to get that strata for those three markers. So for example, I'd like to look at MESA. I would like to look at PURE. I'd like to look at Women's Health Study. And I'm a big fan of making hypotheses and predictions in advance of having the data in. I think we're going to find that. I have some potential academic partners that are working on that right now. But I think we're going to find that if that triad exists, it's not so much that they're going to have lower atherosclerosis than those people who have low LDL. But I believe they will have a low overall risk of atherosclerosis. That's my hypothesis up to this point in time. We'll see if I'm right or not.
But, you know, I wouldn't be surprised if low HDL or low triglyceride HDL is a reflection of a healthier sort of environment, less insulin resistant, less hypertension, less metabolic syndrome.
Completely agree.
So per se, that makes you in a healthier state. Now, in that case, the risk of LDL increase is definitely less compared to ones that are in, insulin resistant state. Then 1 and 1 is not 2, but 1 and 1 is 3 or 4. So you would have to sort of compare the ones with high HDL, low triglycerides, with a low LDL and with a high LDL to see, what is the impact of LDL. And to be honest, I would expect that the impact from LDL, also based partly on my FH experience, will still be significant, although less as the ones that are metabolically more healthy.
So to be sure that we unpack this for the viewer real quick, you wouldn't be surprised if those people with this triad would have lower than average risk factor. So for example, against the general population, they may have low cardiovascular risk factor. However, you would say that they won't have as low a cardiovascular risk factor than somebody of likewise HDL and triglycerides, yet low LDL, right?
Yeah.
Okay, that's super important to make a distinction on for something we're coming up to in a moment. But I actually agree with everything you just said. The key is, though, and this is really important, the key is what you just said is not the impression patients get. If a patient is in a doctor's office and the doctor comes back with an LDL of 170, like we just saw in that study, they're not even going to look at HDL and triglycerides. For the most doctors I already know, and they'll tell me this, they don't. That's already a risk factor all by itself. That high LDL is a risk factor all by itself. Now, I think it's fair to say to the patient, I can reduce your cardiovascular risk even more, although you are currently at a low risk for cardiovascular disease. I think that would be a fair statement to make. I do have a little bit of a problem if we do find that this triad is a low cardiovascular risk factor, that they're being told it isn't, that they're being told, no, you're at a high risk right now for having cardiovascular disease based on LDL alone. And that really is actually the current guidelines, the ones that just got released, as you know. They at 190 milligrams per deciliter of LDL, it doesn't even matter what your other markers are. That is considered to be somebody who's at high risk and should be taking I think the recommendation is the highest dose statin that they can handle. I forget the term, that the tolerable, highest dose tolerable that they can have.
But realize that you also include FH patient in that category. And FH patients, and you can debate exact diagnostic criteria of LDL of 190 is sufficient, but FH patients by definition, and that's what I see also in the studies that I've looked at, are at an incredible high risk for cardiovascular disease, even if their HDL is in the normal range, and even if the triglycerides are in the normal range, because most FH patients do not seem to have a lot of high triglyceride and low HDL. Of course, it's possible, but it's not a common factor. And what's also intriguing, and we don't really understand that completely, patients with high LDL seem to be less prone to develop diabetes. So they're somewhat protected of getting diabetes. And that's also, taking it.
That's pretty interesting. I hadn't actually heard that before. That's pretty interesting to me.
Yeah. So
look.
It's almost, FH patients are not prone to have this metabolic syndrome, diabetes type of feature, but simply because their LDL cholesterol is very high, they're at quite a high risk that needs to be addressed by lowering cholesterol.
So now we're coming into my favorite 3-word phrase. You may not know what it is yet, but I've been excited to get to it. Now look, this is basically a graph, or it should say a chart, that when we're talking about this subject, it kind of goes like this. Whether or not you're talking about a drug that does it or not, when I say, hey, take this pill, do this exercise, whatever it is that I say, it's going to reduce your chance of a fatal event of heart disease by 3%. It's going to reduce your chance of a non-fatal event by 20%.
No.
What happens is internally we go, oh, okay, so it's a win-win. I'm absolutely going to benefit either from dying less or from having a terrible event more.
Yeah.
But my problem is that we don't know if this is what's actually happening, that a thing that we do could actually have a net negative effect in some other respect. And that's why my three favorite words, which are coming, I'm actually going to skip over that, but that had to do with the statin trials, is many studies tout changes in risk for cardiovascular disease mortality, yet show no difference in all-cause mortality. Those are my three favorite words together, all-cause mortality. Doesn't this run the risk of misleading people to assume there's overall benefit where there is none?
For me, it's quite simple. I think reducing events is actually more relevant than reducing mortality. And the reason is that we've become really good at addressing the acute phase of a coronary event, or even in stroke. You know, we're able now to intervene, and like I said, in the 1980s or 90s, 10 people came in a night and 5 didn't make it out. Today, 10 people come in every month and 9 make it out and do pretty good. However, the damage is done. So there is a sharp increase in morbidity related to the event. So not only do people need to take more drugs to prevent events, they're also more likely to develop heart failure. They're also more likely to develop all kinds of other metabolic problems that really have an impact on quality of life. So what I always try to achieve is not to reduce mortality, because that's going to be quite a challenge, but to increase healthy lifespan so that you push forward the morbidity more closer to the mortality. I'm not quite sure, but I think somebody once calculated that if we would eliminate cancer from our disease spectrum, everybody would live longer, like 3 months or something. If we would eliminate cardiovascular disease, everybody would live longer, 6 months. In that sort of context, it's not that what you think. You think, oh, if we eliminate cancer, everybody will become 150. No, it doesn't happen. You extend your life expectancy in general, but the big thing, and I think people are insufficiently realizing that although we're very good in managing the acute phase, we're getting overburdened by trying to manage people in the phase afterward.
I agree with so much of what you just said. Again, I got to summon up Peter Attia again. He calls it health span versus lifespan, and he may have picked that up from somewhere else. But I am of the same mind. I would rather trade a lower lifespan for a longer health span, right? I don't want to spend a lot of time in the broken stage. And I think a lot of people would agree with me on that. Yeah. But here's the catch, and it's actually one I don't know how to solve. We can look at something like all-cause mortality, and even though all-cause mortality is hard to look at, all-cause mortality is easier to look at than all-cause non-mortal events. So the problem we have is that if you have a study that's looking at like MACE, right, major adverse cardiovascular or coronary heart, I don't know, whatever.
Cardiovascular events, yes.
Cardiovascular events, yes. When it's the combination of both mortal events that are actually going to take you out versus something that's actually a major event that may impact your quality of life, that would be great if we could compare it to a non-MACE, right? A non-cardiovascular disease MACE. But we can't really easily do that. There's no real easy way to determine, for example, if somebody in a study who was part of the intervention group had gotten cancer and survived it without there being a lot of poring over adding that as an endpoint, right? So in that regard, it's not that I'm trying to make the claim that if you take cholesterol-lowering medication, you will necessarily have a higher risk of quality of life altering events that are non-cardiovascular related. But it is out there. It is something that people are concerned about, certainly something I'm concerned about, because I would like to be able to make that comparison.
Yeah, the problem if you use total mortality as an endpoint and you start powering trials to show that outcome, it becomes quite difficult, because you need more patients, you need longer periods to reach total mortality outcome. And I think maybe for some of the newer drugs that's going to be done, but definitely not for the statin drugs. You know, there is nobody who's doing any investment in new trials looking at those kind of outcome numbers. Most trials were actually not powered for total mortality, but just for major cardiovascular events. Although in some of the trials, you know, surprisingly, there was also a total mortality benefit effect. I think it's difficult to make that distinction like the way you try to put it forward. There is, you know, we record in trials all kinds of events that happen, although most of them should be related to the intervention or to the underlying disease. But we monitor, you know, progression of liver disease, renal disease, cancer, cerebral or neurological problems, from the perspective to observe if there was a relationship with the intervention. But on the other hand, you know, having not a debilitating stroke or having a large myocardial infarction that hammers out 2/3 of your muscle in your left ventricle, and you're only able to do 6 paces, and then you need some extra oxygen, is something, you know, you don't die, but you know, your quality of life is severely affected. And that's why I feel quite strongly that enhancing that healthy lifestyle is our ultimate goal. That's where a lot should be gained. And realize also that one of the challenges we're facing in modern medicine is that, you know, we're seeing fantastic developments in new treatments and new approaches and devices, you name it. But the problem is that the price is becoming exorbitant, and that although they're available, nobody is able to afford them, even in wealthy economies like in the Netherlands. Even new drug developments like PCSK9 antibodies or SLG2 treatment for diabetes, people are very critical about that. You know, they say, oh, if we incorporate that in our armamentarium, it's going to heavily impact on our healthcare budget. Can we afford that? And that's going to get bigger and bigger and bigger. You know, when we look at new developments in lipids with Lp(a) silencing RNAs, very exciting. But what's going to be the price of these new treatments?
Yeah, I want to get to some questions real quick. We're going to have to kind of speed it along. Thank you so much, by the way, for being generous with your time to allocate a couple hours. We have about 26 minutes left, and we have quite a queue. So I'm going to try to roll through these pretty quickly. Janet asks, are there any CAC scan studies on people pre and post statin therapy?
Oh, yes. Yeah, so CAC stands for calcium score, CAC scoring. And something strange happens here because we do associate a calcium score with an increased cardiovascular risk. We consistently see that patients treated with statins, their calcium score is actually increasing. And that's quite paradoxical because we would expect that if risk goes down, that imaging risk factors would go down as well. So it was confusing, and they're now looking at more intricate measurement of these calcium, and you see a discussion between calcium plaque forming, or what we call spotty calcifications, and the one could be a reflection of plaque instability or of plaque progression, while the other one could be actually a reflection of plaque stabilization. So that by removing some of the lipid core elements, you sort of free some of the negative charge fatty acids that have a tendency to bind with the positive calcium ions. And that is not a reflection of being in a more vulnerable environment, but which is usually associated with more lipid core in the plaque, but with a more stabilized plaque with less lipids, more smooth muscle cells, collagen, and maybe also slightly more more calcium deposits as well. So it's not as easy to interpret as we thought it would be.
Eric asks, does he know how to, as in you, know how to access databases that could test this triad? And by the triad, I think he's referring to the triad I was speaking of earlier, the high HDL, low triglycerides, high LDL. As in when I guess he may be referring to like when I was mentioning MESA and Women's Health Study and Pure. I guess he's asking if you have access to be able to test any of these.
Actually, we have in Holland a large registry, which is 165,000 inhabitants from the northern provinces. Where we
jealous. I'm jealous.
Move over. and we collect everything on these people, from hair to feces to urine to DNA to plasma, etc. Now, the only problem is that a lot of money was invested. So if you want to have access to the data, you have to pay. It's not.
How much does it cost?
Depend, of course, on the amount of data you want to have, depending if you're part of the university or not of the university. You're definitely talking about between 5,000 and 10,000 euros or dollars to have access to that. Yeah.
So if I did a funding campaign, raise the money, would you be our go-to person to do the query for us?
I'm not in charge of the registry. I know that it exists. I work in the University of Groningen, so I know the people that are doing this. The advantage is what you want to know is pure data. It's not like you don't want to have samples to do measurements. That makes it more challenging and costly. So I think there's a fair opportunity. I do think you need some academic involvement as well. I don't think they're just going to hand you data even if you pay from a non-academic environment. So if you can get somebody involved with that as well, that's how it works.
You realize the irony of this, though, right? Like I'm from engineering. I'm used to being awash in free data. Like Google can't wait to hand me off things, and I can't. And this is one of the things that I find very frustrating about being in this space is if I didn't come in from a particular direction that happened to be within an academic institution and so forth, looking at existing health data that may be very meaningful to the people who are especially hyper responders in this group. It's a bit frustrating. That's all I can say.
I'm sure you're connected with people locally that can maybe support you in that, and I can support you in that as well. But they are quite critical to whom they share data. It's if a pharmaceutical company would buzz the bell and say, "Can I have the data?" That's going to be a big issue. That's not going to be
sure.
So they want to have some sort of control of what happens with the data, that it doesn't end up in places what they feel is not ethical or it's not used in a proper way. So that's one of the reasons why they are monitoring that as well. We have a lot of issues with getting data out and taking a long time to get access to the data.
I would definitely argue it's for very ethical reasons.
Yeah, we have access to some data. I can always ask if we can sort of do a fishing expedition to see what kind of numbers we're talking about. We looked at particularly about LDL levels in the 99th and the first percentile to see what kind of people were they. That was some interesting information also. Yeah,
sure. Okay, let's. So this next question is a bit long. But because it involves FH and because it involves children, I'm going to give a little bit of latitude on this one. So I hope I do justice to it. Kelly asks, my son has familial hypercholesterolemia. His numbers freak doctors right now. I took him for many opinions, and all doctors suggest statins at the age of 9.
Yeah.
But not one of those doctors could answer the question, why now? Will it affect his growth? Why can't we wait until he is done growing? I didn't put him on statins until he was 15. The doctors were very satisfied with the test results, but I was concerned. His good cholesterol dropped too. He got mono, then the flu, and a constant cough. He was always tired and his lower back constantly hurt. I lowered the dosage, but he still complained. He has been off statins for 3 months. He hasn't been sick and he feels great. I'm sure his cholesterol is back up over 400 plus. What age do you think statins should begin? Before you answer that, of course, he's going to answer in general because we're not giving any personal medical advice. He is not allowed to, and of course, I wouldn't sanction it. So he's speaking in general for anybody who might have these kinds of things observed. So, sorry, go ahead, Peter.
I tell you what we do in the Netherlands with these children. So, because of our national screening program, we have thousands of children with FH. And we tend, depending again on lipid levels and also, how willing patients or children are open to treatment, but we start usually between the ages of 6 and 8 with statin treatment. Now, one of the most important is, there's actually two really important reasons why we start so early. The first reason is that when these children come to the clinic to be interviewed by one of the pediatricians, and we have a pediatric cardiologist who's really good at this stuff. So when he sees the child for the first time, he always asks them, do you smoke? And then the children are very, they say, no, don't. And then he says, okay. And he writes down, does not smoke. And then he looks at them and he says, are you going to smoke? The children again say, oh, no, we're not going to smoke. I was not going to smoke. And then pulls out a piece of paper and he says, sign here. And the children actually sign. Now, it sounds like a sort of stupid charade, but he did some research. All the children that were approached in this fashion, none of them started smoking.
That is fantastic. That is fantastic.
There were actually children at 12, 13 who already smoked. None of them stopped smoking. Yeah. So one of the reasons, if you want to address this, the second reason is that when you do this early in life, this becomes sort of a second nature. He always compares it to brushing your teeth. He says statins is like toothpaste, but for your arteries to keep them clean. So I start early because it becomes such a natural thing that when they're 13, 14, or 15, they're not saying, my parents want me to take medicine. I'm now independent, grown up. I decide for me, I'm not going to take it. It's like toothbrushing. You don't stop brushing your teeth when you're 14 or 15. But starting medication when you're 14 and 15, not only in FH, but in any type of disease, diabetes is very famous for that as well, is tough. And usually you end up that you won't be able to do anything until they're sort of adults themselves. So we do think that statins are safe. And if you talk about growth and development, we've done some extensive research within the context of the parameters that we can study. We found no signs, no inclinations of having any negative effects. And what I like, particularly of starting very early, is that, I try to explain to you that the disease starts early, but the early phase is very modifiable. You can sort of really regress atherosclerosis, which is absolutely impossible when you start at an older age. So that is why our approach in the Netherlands is to start at a young age, and of course see if patients and the parents are able to get on board and participate, and see if the children tolerate it. Now, intriguingly, what I heard from him is that tolerability issues very rarely exist in children. It's not as common as we see in adults, although there are some children that do present with muscle type of complaints, but it's not very common to find this.
I do want to chime in real quick, and I don't want to take too much of this time. I do have a little bit of a problem. I try to avoid the statin discussion in general. I'm more interested in the lipids themselves than I am in drug treatment for them, in particular with, I know that there's a lot of, it's like a whole nother front in a way. But there's one thing that I feel is prevented me from being able to make an assessment myself of true side effects of statins, and that's by their existing design. They have a run-in period, which a lot of people may not know what I'm talking about, that effectively, when they run the trial, they get all the participants to first take the drug for, isn't it standard for 2 weeks? Is it 2 weeks or is it longer? Or does it depend?
It depends. Usually it's 4 to 6 weeks.
4 to 6 weeks. Okay, so I'm even less happy about this. So the problem being that for those people who would feel side effects, they're going to be more likely to abandon the trial or say they don't want to continue or something along those lines. And therefore, the final pool that then gets randomized doesn't include people who would be most likely affected by the drug in question. And I think that that creates a natural deception level, whether intended or not, as to the outcomes having less side effects. And I think that that's something that happens with statins because, granted, again, could be confirmation bias. I've certainly known a number of people who have gone on statins and said that they've dealt with a number of the deleterious things that are commonly associated with it, such as like muscle pain and fatigue and so forth, and that once they left it, they felt better. Now, how much of that is psychosomatic, I can't venture to guess because I don't know them myself. But this came from people who weren't necessarily already on statins or that familiar with it in the first place. So my preference would be that they didn't have this run-in period so that we could actually get a broader and more complete picture of what the true side effect outcomes would be.
So just a small comment, because I know you have a lot of more questions. If you look at the major statin trials, there were only 3 that had a run-in period. The other ones did not. If you
it didn't have a run-in period. Okay.
No, it's only 3 trials that have a run-in period. And if you look at adherence rates in the trials with running and without running, it's not really that much difference. So the rationale behind it was that, these trials, you need to have sufficient power and sufficient patients that continue and complete the trial. And they wanted to make sure that adherence was something that would be better if you had a run-in phase. In terms of reported side effects after the run-in phase compared to trials without, there was not a huge difference. In terms of side effects, very short, I had one patient. She was an elderly woman with FH and diabetes. And I started her, and this was in my early career as well, with 1 statin and the 2nd statin and the 3rd statin. Every time she would come back, she would be more angry, more upset because she felt horrible. She had muscle ache, she was nauseous, she had mind blanks, and she was very angry with me. Then one time I wasn't able to do the clinic and somebody else did the clinic for me. Now, he was a bit of a sly guy, so when she started again coming in and complaining, he said, "Listen, my sweet lady, I have something for you. I shouldn't be giving it to you, but I think you really need it. This is a new drug, hasn't been tested yet, but it's one of the safest drugs that we ever found." And he builds a whole story around it and gives it to her. So, of course, she comes back in 3 months and she doesn't see him, but she sees me. And she's again very upset with me because she said, "That last doctor, that was a good doctor because he gave me something that really worked. My cholesterol is low and I feel fantastic." And he gave her actually the drug that I gave her the first time, which was 40 milligrams of simvastatin. So it shows you it's so difficult to really fathom these side effects, and that it's
right. You're referring to the nocebo effect, which is people believing that they're having symptoms that they may not be having.
And don't underestimate that. There's some interesting research going on in placebo effect, which is the opposite of nocebo effect. And they even found a marker, and they found SNPs associated with people more able to have this placebo effect. And these are extreme sometimes effects, where you do almost a surgical procedure and you do nothing and people feel a lot better. So it's something that we still not completely understand, but I'm quite confident that the reports that we see in observational studies or in clinical practice are for a larger part a reflection of nocebo and not so much the statins themselves.
So Jay Hike asks, I believe because of glycation, the ApoB100 is not recognized by the liver, hence the increased residence time, question mark?
Modified ApoB or modified LDL particles, I think it's more the size as the modification, because when we talk about oxidation of LDL particles, that actually doesn't happen so much in the plasma. That happens in the vascular wall. That's where the real damage is done and where macrophages are really eager to attach it. But the size, the small dense LDL particles do tend to be to circulate longer and be less easily removed by the LDL receptors than the larger particles. Yes.
So L. Cathy asks, can LDL be present and not cause plaque?
If it's low enough. And I think, one of the discussion points that sometimes comes up is what is a normal cholesterol, or what is a normal value? And we tend to believe that normal is that you measure everybody in the population and you get a bell-shaped curve and you take 2 standard deviations left and right, and then you say that's the normal range. Another way to look at normal is what is the level where you do not see atherosclerosis. And to make it a long story short, that level is roughly an LDL below 60.
Below 60?
Below 60, yeah. That's what we think is a physiological LDL cholesterol.
Bill asks, and actually before I answer this is, I believe, the last question from social media. If anybody has any questions for Peter in the chat, now is your chance because we're about to run out of time. It's just like 7 minutes left. Bill asks, what does he think about, oh boy, Vladimir M. Sabatin's work, wherein he disputes that lipid deposition is the initiating factor for atherosclerosis. Rather, it begins with extensive intimal hyperplasia and lipid deposition occurs much later.
No, I completely disagree with that. And not only because of FH, sometimes people say, yeah, you always talk about FH, these are rare diseases. It's true, but they do prove a very good principle. But realize that atherosclerosis, and we have really beautiful data on that in post-mortem examinations in children that died from other causes, where you can see already at ages of 3 or 4 the first stages of plaque formation. Now, in these children, they don't smoke, they don't have hypertension, they don't have other risk factors, and it's purely associated with the high LDL cholesterol. So I do believe that high LDL is the driving force for this in general. There might be exceptions where you have people with really strange endothelial cells or something, or immune system, but in general, LDL is really what's driving it.
So I haven't gotten any questions in, but that's okay, because I had one that I'd been holding on to this whole time since you showed that first chart from the AAS study. Let's talk Mendelian randomizations again, just for a second, to kind of set it up for the viewer. What's neat about Mendelian randomizations, or at least what we hope is neat about it, is that it's a way by which some genetic predisposition for having high or low LDL levels becomes kind of its own way of conducting a randomized trial. Exactly. Now, without getting into deep details on it, there's an issue that I have, which gets back to the problem with FH, which is, does it not just affect LDL levels, but also impact a cell's ability to uptake lipids or lipoproteins? And what I want to do is I want to actually look at those SNPs, the single nucleotide polymorphisms, that do affect LDL levels, but do not affect lipid metabolism of the cells, especially endothelial cells. And I know a place where we're going to disagree is whether or not we can be sure that cells never require cholesterol to come from a lipoprotein. I think that ultimately as we advance more in our knowledge, we're going to find that indeed they do use it. And then indeed there is a need, maybe not on a constant basis, but one that if the need arises, they are reliant on it actually as a means to get raw material, particularly of cholesterol, because cholesterol, as you know, is very hard to synthesize. But with that said, if you did know you had healthy endothelium, if you knew the cells could function entirely, then I want to look at SNPs that result in higher or lower LDL for a different reason. And one of my favorite examples is glycogen storage disease. Glycogen storage disease results in dyslipidemia, and you actually see that there's been a lot of studies where they've said, this is fascinating, they have high levels of LDL, yet they don't have atherosclerosis. In fact, a lot of times they'll even have a thinner IMT than their likewise counterparts. I myself would be very interested in a study on these SNPs that don't impact lipid metabolism of the cell. Would you be interested in those studies if I can actually get one together?
Let me comment first about your remark that there are cells that need LDL. And although there is not many of them, we do have individuals that have a complete loss of function of PCSK9, and their LDL levels are in the range of 5 to 10, 5
right.
to 10, so extremely low. There is no indication that they have any negative effects of that, except for a very healthy vascular system. So I based on this limited amount of information, it doesn't seem that LDL is really that important. And I know that some of my counterparts even say, we could obliterate LDL and people would be, I'm not convinced about that. I think, LDL is there and in biology, and, there must be a reason why we have LDL, and we can discuss if that optimal level is 60 or 50, maybe even as low as 25, because that's about the range that we've studied so far. But I don't think we can sort of say, get rid of LDL. I don't think that.
Well, and that's why I wanted to get back to all-cause mortality, or for that matter, all-cause quality of life. So as I conceded earlier in the broadcast, I think if we could take all of the LDL particles out of your body, out of my body, we won't die of cardiovascular disease. In fact, we won't have cardiovascular events because we can't have the progression of plaque without that. But the same could be said about macrophages. If we take out monocytes and we take out the capability, we won't die of atherosclerosis. That's not the same as we won't die, period. Or for that matter, even that we'll have a reduction in other causes of death. And that's why I'm interested in anybody who has a mutation like the one you described with the PCSK9. If they have this nonsense mutation, and if they could take out cardiovascular disease as a whole category, they should have greater longevity, right? Yes. Like you would expect, just like people who have A-beta lipoproteinemia, who have, also very extremely low levels of LDL, they should have longevity if, in fact, LDL particles served no benefit of any kind. And that's why I'm interested in where LDL particles may be part of the immune response, maybe part of the reparative response, et cetera, because that suggests that there's a trade-off, that if you bring LDL down low enough, some other things are being impacted, things that we may not have our attention on, but some of those things we do have our attention on, such as binding to pathogens, such as providing alpha-tocopherol on board and so forth for the antioxidant defense. These things are all very relevant. So again, if you find that, like if there's a homework assignment I could give you, you can find any of these nonsense mutations that result in that, for that, especially if you could get them all together and say, aha, it looks as if in this population as a whole, even if it's a rare SNP, we do in fact see that there's a longer lifespan. I would be very interested in that data, but I haven't been able to see it in what I've been able to research thus far.
These SNP panels to do GWAS or to do a Mendelian randomization are usually based on GWAS analysis of millions of SNPs to see which gives a signal for higher or lower cholesterol, and predominantly it's of course the SNPs that code for a protein that we know is associated with cholesterol metabolism. But these are also SNPs that code for PCSK9, for HMG-CoA, and there's a whole spectrum of SNPs that are associated with minute changes of LDL cholesterol, not necessarily being involved in lipid metabolism per se, like PCSK9 is
Right.
not
I want those.
a protein involved in lipid, it degrades another protein, and that sort of has the impact it has on lipid metabolism because it happens to be the LDL receptor.
And that's what I'm interested in. I'm right now trying to work with another researcher on seeing if we can get together.
There's a few of those chaperone proteins that seem to be involved in lipid metabolism or in cholesterol levels, I should say, but are not actually directly in the lipid metabolic pathway like HMG-CoA or NPCL1 like one protein. They're chaperones, like PCSK9 is like a chaperone for the LDL receptor and determines if it's degraded or if it's not degraded. So that's a new area of research where we actually are now quite active in, because there are still quite a number, FH is still sort of my mainstream of attention. There's still a lot of patients where we find completely FH phenotype, all the characteristics and familial characteristics, but we don't find a mutation in one of the canonical genes or even in genes that we thought might be associated. So there are still some black holes or black spots that we try to uncover how we can understand and explain that, and maybe even some future.
Well, my research may really apply here because, again, I have a bunch of people who I'm quite confident were not at FH levels before having gone on a diet. So there is a metabolic component, granted a very new one because of the ketogenic diet. Anyway, we should probably wrap up here in a sec. But I want to kind of roll this real quick on the credits. I want to thank Siobhan Huggins for producing this. And I want to also thank all the patrons, for which, of course, this kind of content just simply wouldn't be possible. I also want to ask real quick, Peter, where can people find you?
They can find me on Twitter.
On Twitter. And you ended up with your last name as a Twitter. Like, how did you do that? Did you started Twitter back when it started like 10 years ago or something like that? I don't even know how you pulled that off.
I have to admit, my name is not that common. So, that plays a role. And realize it's Lansberg.org. It's not .com. That one was already taken.
I don't think that'll be a big problem.
Available.
Well, thank you so much.
My Gmail as well. I was an early adapter with that one for sure.
Thank you so much for taking the time to chat with us, and I look forward to seeing more on your work later.
Okay, take care, Dave. Thank you.